Thank you, everyone. Happy Monday. We'll go ahead and get started. Is anybody on from DHHS?
Hi, this is Allison.
All right, thank you.
Robin?
Anybody else? Robin? Huh, can't hear anybody. Robin, can you speak one more time?
Hello. Testing. 1, 2, 3.
There you go. I must have my mute my sound on really low because I can hardly hear anybody. All right, much better. All right, thank you. Then is anybody else on from NPHL? Pete, I saw you on.
I'm here, Karen, yes.
All right. Emily is on vacation this week, a well-deserved vacation, so we wish her a fun time because they've been working very hard in the laboratory doing our specimens. I swear they continue to increase in numbers, so we're trying our best. And I want to thank everybody for joining, and if you could, as a reminder, just sign in into the chat box. Let me know if you cannot find it. If you could fill in your full name and your place of residence, or excuse me, your facility name. Okay, getting started, I think we'll talk a little bit about this, the state of the state. If I may say, is John on? He was going to be on. He might just have been delayed. Robin, I think I'll have you go ahead, and if you can share anything regarding anything new at DHHS, feel free.
Well, laboratory related and NPHL related, we are going to start focusing NPHL testing more on outbreak situations, as we have done in the past and regular, disease surveillance times. And it would be, it is a time where laboratories need to start looking more towards commercial testing for COVID. So making those connections and getting those relationships to start sending those tests to a commercial lab rather than the NPHL, as NPHL has to do a lot of other testing, like enteric testing, arboviral testing, other diseases that have not stopped during the COVID season. So we will be trying to get some communication about that. So please utilize Test Nebraska as well if you'd like to with your local health departments. But we are going to try to get more communication out about that for specifics. So that's an update from us.
That's good. Good to know, Robin. As you formulate your communication, I hope to put out a new lab alert for NPHL. So when those finalizations come in, I will like to try to get that out, hopefully this week. We were also going to ask you if the ICS forms, the 213s, are going to change anytime soon. I know you had mentioned once they might go electronic.
Yes, we're going to be putting those in a RegCap survey rather than the form itself. So we'll be adjusting the request protocol so that it's easier to track and approvals can be given, and less forms and papers get lost in emails. So we will be working on that this week, and hopefully we can get it implemented by next week.
All right. And please share what what REDCap is, because I think that a number of laboratorians probably are not familiar with that system.
It's an online survey system that you go in, click a link, and fill in the survey, like SurveyMonkey, but better. So that's what that is.
But as a laboratorian or a clinic, they don't have to go into REDCap. They would send their request right to the local health department, and it's the local health departments that use REDCap.
We will be working on the protocol.
Okay.
And developing that.
All right.
So
we will await that information. Thank you. Thank you very much, Robin. Is John on yet? All right. Well, I'd like to move on then. We'll maybe catch him toward the end if he has anything new to add. Pete, would you take a minute just to talk about some of the changes we've had here?
Sure. You hear me, Karen?
I can, yes.
Okay, so good morning, everybody. I know this has been a busy time for all of us, and I just wanted to share that Nebraska Public Health Lab has been testing since the end of February for COVID-19, and we currently have surpassed over 25,000 tests in the public health lab. Our clinical partner at Nebraska Medicine, I believe, has also surpassed 25,000. So we are supporting roughly half the testing for the state of Nebraska still, even though other laboratories have verified tests, and we're working with commercial labs as well, which is very, very helpful for all of us. So what it's come down to now is the Nebraska Public Health Lab is trying to get back to its day job, so to speak. And of course, this is one of our busiest times of year in the Public Health Lab because of West Nile, GI pathogens, screening, such as cryptosporidium testing, the ARLN antibiotic resistant lab network is very busy at this time. Our biological and chemical terrorism laboratory is busy, even though we may not be testing a lot of powders and such. We still have to keep up with our quality assurance program for PT samples, et cetera. So we are very busy in the public health lab. Thus, Robin had stated that we now are going to be more focused on doing testing for outbreaks, identification, maybe testing symptomatic individuals that might show up in such places as a nursing home. We are not available for nursing home surveillance, large volume surveillance. We are not available for pre-op screening, where we've seen a few of those sent to us as well. We are not available for the drive-through clinics or any other large-scale surveillance testing. We just do not have the capacity to do these tests at this time. Currently, our capacity in the public health lab is about 400 samples per day, and 5 days a week. We're trying to get back to normal work hours instead of 7 days a week. Any stat testing that needs to be done on weekend, our partner at Nebraska Medicine can help out for one-offs, so to speak. They are open 7 days a week. The issue, I just wanted to state that the issue with reagents, swab kits, other consumables is still a challenge for us at times. We are working with our national laboratory or warehouse at IRR with CDC to get reagents. We seem to be okay at the present time, but that's always a challenge for us as well. And it's a challenge for all labs trying to keep up with the reagent supply. So that's an issue that we have to deal with as well. So I'm open for questions. If people have questions, that's kind of where we're at with the public health lab. We're here to help as best we can. Karen?
Pete, we do have a couple of questions on chat. One is NPHL still going to handle hospital staff, those that are hospitalized? Or no, excuse me, the hospital staff themselves.
Probably not. No, I would say no. We cannot support testing for hospital staff. We really need to be more open for testing to detect outbreaks. I would say that the hospitals need to work that out with their commercial systems or their in-house laboratories to get that testing performed.
And yes, that's very true. That is what's going to be in our future lab alert, that we are encouraging people to move forward with this surveillance-like testing, to really consider moving on to other sites, other commercial sites. And I do get a note from Jody Garrett, thank you. As of yesterday, Jody said that she had 32,000, a little over 32,000 as of yesterday. So good for you guys too. I know that you're going to even be probably increasing those numbers quite a bit.
We do appreciate the help of Nebraska Medicine, thank goodness, because they have multiple platforms that they can run, and that has been very, very helpful. A lot of those 32,000 that Nebraska Medicine has tested do represent public health as well. So it isn't just their clinical patients that they're doing.
Yes, and they are our partners there at Nebraska Medicine. And so if people question about where to go, there are some sites across Nebraska that you can look into. Obviously, Nebraska Medicine, I do know that Brian in Lincoln, we've got Test Nebraska, I think at least in Lincoln, if not multiple sites. I'm not sure the status on that. Pete, do you know of other laboratories across Nebraska that are testing right now?
Well, there's multiple labs. A CHI core lab here in Omaha is doing quite a bit of testing.
Right.
There are other labs that have set up some of their, the Abbott test, I believe, has been set up at some labs. I believe that Cepheid has been set up at some labs. So it's hard for me to get a handle on how many of them are. We have been helping labs with verification testing by giving them positive samples. So yeah, there's a lot of them getting set up, which is very, very helpful in this whole process.
Yes, yeah. And so that brings me to ask if you could, in the box, we would like to know what kind of testing is being done out there, not trying to pry, but we would like to be able to recommend other hospitals for testing if we can, because of some of the changes happening here at NPHL. So if you have brought up any new testing platforms at your hospital, would you please type them into the chat box as we continue talking? We would like to be able to share that information. And also be interesting to know what is out there, and we greatly appreciate it. I wanted to just take a really quick moment and review what we talked about last week, about packaging and shipping and some of the changes that we're also going through here. I'm going to change my screen right now so that we can kind of look at some of the documents here. So we basically reviewed the two types of couriers that we have in Nebraska. Between Lincoln and Omaha, we do have a private or contracted courier that is exclusive. So meaning that if we transport with them and they don't, I mean, being exclusive means that you cannot carry any other non-medical devices or things. So you cannot carry mail bags or bank information. You cannot carry other supplies from other companies. You also cannot carry, obviously, food or other people. And sometimes that's an issue with some couriers that they have to carry these things. So Outside of Lincoln, Omaha, then, and some, you really have to know your courier. Some even in Omaha and Lincoln are not exclusive. They are required to carry those other things, and maybe not required, maybe they're carrying food too. So because of that, if they're not exclusive, they are considered, our specimens should be considered a Category B. However, if you are using an exclusive courier, your specimens are not subject to, and that's why you could just give a biohazard bag to the courier, and it's still very, very legal and allowable. However, when you have a not exclusive courier, just giving them that bag, it does not follow the DOT regulations. And I know that the question has been, how about our coolers? They sometimes are even marked, sometimes are even drop shipped as Category B. However, they are, because of DOT requirements, they have to be triple packaged. Well, where does that come from? Let me flip over. Do you now see Table 3 packing requirements for Category B? Does everybody see that? Just need a confirmation that you guys could see that.
It's here, Karen.
Okay, thank you. So if you go down to this outer container section, what these box requirements are, it does have to have a rigid container. Now, if not so much exempt or not regulated, it's not required. For Category B, it is required. How strict, there's only a few things that is required on that outer container. Obviously, it's a lot less than what we would have with Category A, as you see many in the Category A column. But in Category B, the only recommendation there is that, of course, it has to be properly labeled with full name and phone number of the responsible person. It has to have the full name, address, city, state, zip code of both the shipper and the consignee, or consignee, which is really the recipient, the person receiving the box, which would be us. Markings and labels, it only requires the Category B label. Obviously, there's a lot more to Category A then. So just keep in mind that that is definitely required for anybody whose courier is not exclusive. And where you can find this information, if you go to our website, on that very first page are menus to the left, you'll see biological events. And if you go under the NPHL, or excuse me, LRNB protocols, below you'll see our bench guide. You'll also see the APHL bench guide, which is just a little bit different. It's a lot more detailed for those of you who are LRN. And then, of course, the Blue Book. The Blue Book is quite large, but it contains everything LRN labs need to know, and also has just a huge section on packaging and shipping. So all good information to know. So as I go back into our agenda, the other thing that I wanted to review basically is about aerosolization. For those of you that were not on last week, I'm sorry, I'm going back again. Yes, and that aerosolization is here where we talked about, let me move my chat box here real quickly. aerosolization in point of care, and how obvious, well, how obvious it is here in this image. You can see the splatter only because of the fact that a fluorescent dye was put into that specimen, and you put a black light to it, you can see it. But it is nothing you can see visually to a human eye. And even if you think you're using your best technique, it's still very, very possible to have splatter, especially as you pipette that last drop out. It is aerosolizing, and we just don't know it. So it is so very important that people, especially in the clinic areas who probably do a lot of point of care, that you have good PPE on, and also probably some sort of a mask. And we even recommend eye protection, some sort of face mask. And I know that last week I had promised a couple of people face masks. I just realized I didn't get those out, but I promise I will this week. And if you want face masks, I'd be happy to supply you. We've got a ton of them here. I actually pre-ordered a lot of those before we ever knew what COVID was. So goggles too would work. If you would prefer, you probably could use a desktop shield of some sort, but you have to make sure that desktop shield goes as high or higher than the person that is actually doing the test, because that aerosolization comes around to the side. So with that, let me just make sure that I've got some other questions. I see people are continuing to place their different methodologies as far as the type of testing that we do. So I know Diane says that they're only doing testing on symptomatic or high-risk patients just for their Nemaha County patients, and you're using that ID now. So that's really good to know, no pre-op testing. I know the pre-ops, pre-surgicals, there's a lot of people requesting it, and it's really, really tough to do. And I think it's something that I know as I talk to my ambulatory surgery clinics, which I am in contact with at least on a monthly basis, that only about half of them are able to test, probably because of the lack of availability. But the other half just really are concerned with the fact that the people are that are tested may not necessarily go home and quarantine themselves like they're supposed to until the time that they go in for their outpatient surgery. So they're worried it really isn't going to pay, but that's their prerogative. They decide what works best for their facility. See if I have any other questions. I hope I'm not missing any. Should the fan be on when doing the COVID-19 testing on the ID now in the biosafety cabinet? Yes, I would definitely recommend. In fact, there is a very structured procedure on how to turn on your biosafety cabinet, let it run for about 10 to 15 minutes, before you use it. Also, make sure that nobody is walking right by you or standing up near you, because that can be problematic with the airflow that goes through the biosafety cabinet. So that's something that I can review. If you guys want to go through more, I can provide other resources for that. I know that our clinics, however, and a number of our laboratories really don't have the luxury of the biosafety cabinet. So that being said, have to rely on doing it on the countertop with the correct PPE. So I see that there's some discussion going on about Cepheid and adequate supplies are still an issue, so there must be a supply chain issue. Has anybody had any luck getting through finding Cepheid supplies? And who do you go through? Might be an interesting topic. All right, let me go back. See what else is on our agenda. All right. So I think I've hit pretty much what we need to talk about. And for the first time since COVID started and our weekly meetings have started, I've decided we definitely really need to reach out, maybe talk about something besides COVID once. And I have asked Kristen Bertrand to speak today on TB. Unbeknownst to a lot of people, I think TB is huge in Nebraska right now. Kristen, you want to kind of explain what the situation is?
Thank you, Karen. Yeah, it's nice to talk about something other than COVID. I've been doing COVID work for the last 6 weeks, leading a team of 30 here at DHHS, so I've been in the COVID mode as well, like all of you. However, as Karen alluded to, TB has not stopped. We do have a record number of cases this year. We had 17 active TB cases as of last year total. This year we're at 18 total cases. So it's been very busy in TB. I took on the position in November of 2019, but I'd been with the program for about 10 years prior and just took a little bit of an absence. So I'm here as a resource for all of you lab folks on the call if you have questions. Really our right-hand person is the public health lab, Karen Stiles, Dr. Iwin, and their team. So basically, we have funding from CDC to do testing. So if you are in need of a smear, a rapid PCR test, you have a suspected TB patient, please work with me in the lab. We definitely can get that done for you. That's why the funding is there to support people that are suspected of having active TB. The lab has been very busy this spring and summer. I've been on the phone with Karen and Dr. Iwin multiple times. We have a lot of activity going on. We've had recently 2 drug-resistant cases tested for CDC testing, immediately for drug susceptibility testing, where we get results back in a couple of days instead of weeks, which is crucial if we're dealing with a suspected drug-resistant case. And really that's sort of unheard of to have 2 in a matter of days. So that's been very busy. Something else that's new with the program is, I know this isn't really lab focused, but we do offer free medication for people without private insurance through private pharmacies, and that process has changed a little bit. So that is an option for people that do have positive interferon gamma release assays or positive skin tests. So that is an option for all you lab folks. If people are asking you, what do people do? If they do have a negative chest X-ray, and that's what the clinician is suspecting. Just another thought that we've had, TB is reportable, or if you have a suspected case, it is reportable. I think we've had 1 or 2 cases this year that were missed, and I don't know why they didn't get submitted to the electronic lab. I think with all the craziness of COVID, things have been slipped and not happened. So if you do have someone you're suspecting, please notify your local health department right away. We like to get on top of these cases and people. We do the isolation just like COVID to make sure we're not having people exposing other people. We also have TB outside of the lungs, so we have samples coming from all anatomical sites, and that too can be infectious if it's aerosolized. So I would just encourage you to work and make sure that if you are doing extra pulmonary site, to make sure it's labeled properly. We recently had a situation where we had the option was not available in the electronic medical record system. So please make sure we're getting correct anatomical site for a TB sample, because it caused a lot of confusion and a lot of phone calls just to try and decipher where that sample came from. I don't know if there's really any other updates from staff, but TB has not stopped. TB is also very serious with a co-infected COVID patient, and we've seen that as well. So it's not a good thing, and there really aren't recommendations right now to treat TB patients with COVID. So it's best if we can avoid it. just a brief TB update. We see a lot of TB in our foreign-born populations. That is just something we have seen more of over the last few years. And also do consider TB if you do have a negative IGRA test or TB test. You really want to look at the whole picture, not just put all your marbles in the lab. And I know you guys are laboratorians and that's what you rely upon, but sometimes we need to really do some digger deeping, and we may need a culture to grow to get that confirmation that it is indeed TB. Or we can have a clinician diagnose a clinical case without laboratory confirmed evidence as well. We don't see that as much, but if we have like a TB in the eye case or something, it's very hard to get a sample from the eye to do that. So that is something that happens. So just interesting facts, as you guys probably don't need to know all this about TB, but it's very fascinating. And like Karen said, it's just something nice to talk about something other than COVID, because I've been a little COVID overwhelmed here as of recent, but it's been good. Karen, did you want me to add anything about TB?
No, that is actually very good. I do have one question I think might come up. We have a couple of labs still in Nebraska that are continuing to do some degree of testing, maybe only AFB slide or smear, or some of them might do the initial NAT test. But we do have situations where a number of laboratories send it out to reference labs outside the state. And that is very problematic in that we have a real hard time getting that specimen back. And is that something that our laboratorians could send to the state instead? Or do they need your permission first?
I mean, in the ideal world, it's great if you can let me know. We don't ever, we want to be mindful of our federal dollars, because we are the testing is funded through the federal tax dollars through CDC. So we do want to be mindful, but if you have someone that's suspected, we would prefer you to use NPHL because we do prefer to do susceptibilities through the public health lab. And then on all our TB samples, we do something called genotyping, which we link cases to see which cases have been related to who and which strains. And so that we spend time having to get those samples sent back to NPHL, and I actually have a call to make to another lab today to get a sample shipped back to the public health lab so we can get that sent off. But that is good for disease outbreaks and investigations, so we know who is exposed to who. And it makes it very helpful. So it is really important. We also do have it is preferred, if you can call me and just say, hey, we have a sample we want to send, this is a situation, 9 times out of 10, I'm going to approve it. If they're just trying to run everything, to rule everything out, maybe not so much. But if you have someone that's a serious suspected with TB disease, please call me. We would love for you to use the public health lab. It makes things a lot easier on our end, coming from a public health perspective. And there is federal funding to support this with our TB patients or suspected patients. So it is a definite option. And it also delays reporting from an outside lab. Sometimes we just don't hear about it for a few days. We could find out a lot quicker through the public health lab. I get calls, and then we can act upon it and make clinical decisions about isolation, treatment, if we have conclusive evidence from laboratory samples. And so it's delayed on our end. So it really is preferred to use a public health lab. And also our clinicians at NPHL have updates from CDC. They go to a yearly conference that the CDC puts on. So they're very well versed on TB issues. So it's really preferred to use our public health lab, where we have a good relationship with. And if you do have to use a private lab for some other reason, that's definitely your call, but really it would be our preference to use a public health lab for cases of TB or suspected TB. We can do NATs and PCRs to get those rapid results, so we have definitive answers for clinicians quicker. So that would be my take on what Karen was saying.
All right, thank you.
That was a nice overview. I have a comment and a question.
Yes.
Comment, first off, genotyping is important, and you brought this up. even when it comes to us putting our grants into the federal government, because they look at how many of our samples actually get genotyped, and our dollars are based on our capacity to get this done. So one comment. Second is a kind of a question. I'm just curious to know how much TB quant screening you are doing with all of these TB cases, and where are you getting the dollars and the funding to pay for this screening process, and how many seroconverts are you seeing in our state?
That's a good question, Dr. Iwin. I haven't spent a lot of time on that. It seems my efforts have been focused on other things. So I'm really unsure, to tell you the truth, where we are with quantiferon testing, et cetera. So
Okay.
that's something I really need to look into. I've sort of come into a program that's had numerous program managers over the last few years. So I've just been trying to clean up stuff and get our LTBI program up and running. And as you know, the grants we're writing, but yeah, definitely something to look at. The IGRAs.
So the health districts themselves, they're dealing with the follow-ups and the screening then? Is that what's happening?
Yeah, and even too, like in NEDS, we get some reports of quantiferons, and usually what I advise the health department to do is not to follow up unless a clinician follows up.
Okay.
That, you know, it's our health departments, especially right now with COVID, they don't have time to investigate every positive quantiferon. If we get a call from a provider that says, you know, we're suspecting TB, that's a different story. But if I'm not aware of a situation, our health departments are very busy even before COVID. So really,
Sure.
we have to prioritize, you know, if someone calls or says there's a situation, or someone's been losing weight for months, coughing for months, you know, has risk factors, foreign born, HIV positive, you know, then we're going to put our attention on that person. But of course, it's something we want to look at. Also,
Sure.
too, the staffing here is just me. And then we do have a TB education focal point who's about 20%. So our program is small. We're low incidence for TB, which is nice. But then too, we don't have the manpower like other states do to do some more follow-up with like latent TB infection and some other project management issues. So
Sure, it's kind of when it rains, it pours. You know, the whole issue here is that I understand what you're saying about following up and stuff, but you always get concerned about the fact that we are seeing so many cases. We're about double where we were at last year. The concern in my mind is, are we not getting to the cases that we need to get to because of all the other things that are going on? So it's always a concern, but I know everybody's working as hard as they can, so that's good too. But
yeah,
you know,
yeah, I
like
think
say,
most.
when it rains, it pours.
Yes, most TB controllers, because I do have experience with, you know, the disease investigations, they've been pulled away to COVID, at least part-time or if not full-time. So it's been harder to stay on top of things, but it doesn't mean TB stops. And I've still been, you know, trying to run the program as best as I can while dealing with overseeing COVID investigations for a local health department that has been very busy. So
we just don't need a huge outbreak of TB on top of everything else.
Yes, we don't need, it's not a good thing with COVID, I can tell you that. So, but yeah, we have had a cluster of cases that have been related through the genotyping has confirmed it. So the genotyping is very good for that. So that's why we encourage folks to use a public health lab so we can tie back the cases. So that is one area we've had of a problem this year. And we're still trying to, you know, deal with that issue as best as we can. But when we have a bunch of cases linked, then it is an ongoing public health issue to make sure everybody's been taken care of and somebody doesn't break down and infect other people.
Yeah. Thank you, Kristen.
Kristen.
Very much appreciate that update. And I can attest that she's extremely busy because I get to send out, I have been sending out this year all the category A's that need to go to genotyping or for susceptibility for MDDRs. So I can attest to it. I just want to backtrack one more time. When we were talking about aerosolization, I wanted to add something else. If any facility that's done any changing of your PPE policies in even the last 3 months, just let us know. I'd like to see if some of our education out there has been helped and maybe convincing enough to have you guys think about changing your PPE protocol. So quickly type in if you have changed your protocol within the last 3 months. So also a couple more things in the chat box. I know that the final comment about the test supplies being short or hard to get a hold of. It does say obtaining Jody says obtaining adequate supplies is still an issue. Cepheid and Roche on allocation. Now holistic or whole logic under control of the White House task force, and they do promise any regular allocation. So wow, that's kind of crazy in our world today, but I guess that's the way it has to be. So with that, I'd like to go ahead and open it up to any other questions, any topics. Doesn't have to be COVID. If you would like to think about or ask, or you've been thinking about some things and have some questions, please let us know. I'll give it a minute. Jody does share that Nebraska Medicine has gone to a universal eye protection when around patients, including phlebotomists. That's definitely something to keep in mind. A lab already required mucous membrane protection when they work with specimens already. So, but that's an area I don't think people think about, that if you are one of the laboratorians who literally go up to the floors to collect or to any of the clinics, certainly make sure that you have a protocol for them. So good to know. Anybody else? Any other questions? Hearing none, then I'll go on and just ask if John was able to hop on, if he had any last minute words. Sounds like maybe he wasn't. All right. We'll continue to bring on other DHHS staff so you get to know them. And I think that in this time and date, it's good to know who our officials are from the state and from NPHL. Future trainings, I am starting to do a Zoom training. It is really merely a review and getting people started to do the actual CDC website train. It's the CDC site that gives certification, which I cannot give, but as long as that's completed, and then to make the fully completed certification, each supervisor must sign off on that certification, and then you're good to go for 2 years on packaging and shipping training. So I'd be willing to work with you at any point to do whatever training, one person or your whole lab, I'm totally okay with. Again, just a reminder, the LPX and challenge sets do come out in July, and believe it or not, that's here in just a couple of weeks. So we'll be beefing up to do some of our LRN projects again. As for our weekly meetings, I think we'll continue doing our weekly meeting here on the 22nd and the 29th. However, starting in July, I'd like to think about going to every other week and eventually go back to our quarterly meetings or monthly if need be. So let me know what you'd like to have. If Mondays are really tough, which I know they are, we could consider really backing off to our quarterly meetings. So, all right. please feel free. I'll leave on the chat for a few more minutes. And I'd like to hear if you've had any policy changes for PPE. Be really good to know, or want to know what kind of testing platforms you're using for COVID and what you have available. It would be really nice to know. And if you would be willing to take other patients other than your own. And I know that is not always possible. With that, I think we're able to cut a little bit short and let you go back to your normal job. And I appreciate your time, especially to Kristen and Pete for sharing. So, any last questions? All right then. Thank you all. Have a great week. Bye.